Good morning. I'm Jeffrey Lewis, President and CEO of Legacy Health Endowment and the EMC Health Foundation. I wanted to welcome you to this really phenomenal seminar we're having this morning with some just amazing speakers. The panel will be recorded, so you'll have access to a recording. All participant lines will remain muted, but attendees are encouraged to submit your questions through the Q&A or chat feature. And we'll do our best to group similar questions and ask our panelists if there's time before the bottom of the hour. It really is a pleasure to be here, and I have the honor of introducing Nita Algadon, who is the healthcare executive with over 10 years experience at Molina Health, most of which has been spent in the California Health Plan. It's probably why Molina Health has done so well in California, Nita, because of you. She joined Molina Health a number of years ago. She's been in a number of positions throughout Molina Health, and most importantly, in leadership roles. When you find a professional like Nita, I assume it's why you're still at Molina Health, you never let her go. And her reputation precedes her. When you think of quality, when you think of patient care, you think of Nita. And the kind of work that she's done over the years is exceptional. She is a pioneer in healthcare, and it's my honor to introduce her to you. And welcome, Nita.
Thank you, Jeffrey. That was a very, very wonderful introduction. Thank you for that. I'd like to welcome everybody today to our forum on the California's healthcare workforce. Really appreciate all of your attendance here today, because it's an important discussion that we'll move forward to with great panelists and wonderful discussion. So before getting started, I'd like to introduce, I have the honor of introducing Senator Lina Gonzalez, who has joined us today to talk about some opening, to offer some opening remarks about the work in the legislature that she has done to increase our access and quality healthcare for all of our Californians. So Senator Gonzalez actually represents about 1 million residents in the 33rd Senate District. She has been and is a strong voice for our working families and really prioritizes and fights for the clean environment, digital equity, our LGBTQ plus community, and of course our women's rights, really looking at also the economic vitality of our small businesses. So Senator Gonzalez back in 2020 chaired actually a newly formed bipartisan committee consisting of 11 senators that were really tasked with reviewing the COVID pandemic and the health crisis there. And as part of her work on that committee, she actually led several hearings informing and strengthening the response to the pandemic, kind of addressing different topics of testing, contact tracing, workplace health and safety issues, and really, addressing the pandemic and how we move forward. And really the bill that she worked on, the SB 1255 for the Equal Insurance HIV Act, was actually signed into law in September 26th of 2020. And that law actually prohibits life and disability income insurance companies from denying coverage to our HIV positive folks. And as a local member of our community, Senator Gonzalez comes from a background of parents that immigrated from Aguascalientes, Mexico. She's graduated right here, Cal State Long Beach, with their degree in political science, and with the master's from Loyola Marymount, and local resident of Long Beach with her husband, Adam, and 3 sons, Orion, Ethan, and Luca. So Senator Gonzalez, we are privileged and honored to have you here today to join our forum, and I will turn it over to you for some opening remarks.
Thank you so much, Nita, and thank you so much, Jeffrey. I can't thank you enough for all of the opportunity to be here, but I want to say good morning to everyone else, and also thank you to Molina Healthcare and Legacy Health for all the incredible work and all of the healthcare workers that have been just steadfast and dedicated to access and equity through this really tough time for many of my residents, but not just my residents, for folks up and down the state of California. And it's great to see so many stakeholders in the healthcare space that will come together even as we're sort of waning off of this pandemic, to still learn and understand what the legislature can do in unison with you. And as legislators, of course, we're always interested in hearing from experts who are on the front lines and who can use our experience to provide us insights on potential policy solutions and help us address important issues. As I'm already sure that you're aware, California, of course, we're facing a very tough and dire healthcare workforce shortage. Across the state, we know that hospitals, clinics, mental health providers, nurses, doctors, even our local municipalities and counties are struggling to hire and retain adequate amounts of staff to keep up with the demand. It's been really tough. In an effort to help address the growing shortages of healthcare workforce across the state, the governor and legislature dedicated millions of dollars in last year's budget to bolster workforce training programs. And I'll talk about that here in a moment. The commitment included $16 million to support the Health Professions Career Opportunity Program to implement programs at colleges and universities for pipeline programs and post-baccalaureate opportunities for students of underrepresented regions. We also allocated another $50 million in grants for new primary care residency programs. And in this year's budget, the governor has proposed a one-time $1.5 billion installment over the next 3 years in care economy workforce development that will create more innovative and accessible opportunities as well to recruit, train, and hire an ethnically and culturally inclusive health and human services workforce. It's very exciting, and I'm sure there's still much more to come and more to learn from you all today. This proposal also includes funds to expand scholarships and loan repayment programs in healthcare and social work for multilingual applicants, with the goal of increasing language and cultural competencies. In addition, the governor's proposal includes money as well to leverage the Department of Healthcare Access and Information Health Workforce Education and Training Council to research healthcare shortages and support more R&D on best practices. However, we know that this is not enough. And again, we want to hear from you to ensure we get this right as we approach our May revise. The state needs to ensure that the one-time investments are continuously reviewed, and in the coming months and years, that we continue to maintain a workforce that is supportive of our communities. Finally, I want to thank you again for all the incredible work through this pandemic. Even before the pandemic, you all were heroes, but even during the pandemic and as we get out of this, you are still considered a hero in my book from all different parts of this state. So thank you again, Molina Healthcare Legacy Health, for all this opportunity, and I look forward to our work together. Thank you.
Well, Senator Gonzalez, thank you so much for wonderful remarks. The healthcare workforce challenges we face as a state and as a nation are phenomenal. They only get worse, and hopefully the use of these kinds of panels like the one today will help us think of new and innovative ways that we can begin to stem the tide in California. Before we turn to our panel, let me turn to you, back to you, Anita, and ask you to give us a sense of what Molina Health is doing in California on workforce development and also post-pandemic.
Sure, thank you. Thank you, Jeffrey. Again, I want to thank everybody for your attendance here. Thank you, Senator Gonzalez, for your opening remarks here and shedding some insight to the legislator, and everyone here for your participation, our panelists that have made the time to join today and participate in today's panel discussion. So from Molina's perspective, right, we have always been kind of committed to engaging and reaching our Medicaid clients, our patients, in all different corners of the state that we're present. And we've always had that high quality approach, whole person care, holistic view and strategy to healthcare coverage for the folks that we care manage and serve, really. And establishing that local presence in our communities really helps us understand the needs of those members, the providers that are there, and we really focus on connecting, right, with the folks where they live, whether that's in the school setting, whether it's at health fairs, whether it's at other events or gatherings that really enable us to connect with the families and folks that are in need in their settings. And in prioritizing this population, especially during the pandemic, right, understanding that access to care and certain kind of stigmas or things around accessing care, especially when you talk about vaccines and things like that, that all pose a challenge. But the way that we operate has always been to kind of meet the members, our members, where they are in their preferred settings, kind of identifying who's most vulnerable and supporting them with focused outreach, targeted outreach to our most vulnerable populations, encouraging that preventive care and the full scope of services, right? It's not just about medical health sometimes, but also linking them to behavioral health care, community supports that are needed, including those resources such as housing, food insecurity, those things that are social drivers of health, right? And that is an activity that, even with the challenges of the pandemic, recognizing how critical that is to support members' health, that we continued through our case management programs. Because really, our healthcare system, as you all probably know, it's complex in its nature. It's challenging to navigate, especially in the advent of a pandemic. So our care management teams have really come in to improve that access, to support our members, to guide them through, whether it's having vaccine clinics, partnering with our counties and having vaccine clinics and access to care that way. Because really, staying healthy shouldn't be a chore for our members. And that's where we want to come in and bridge that gap and ensure that we're looking at our members from that holistic view and connecting them in any way that we can, developing those targeted programs or interventions to really get them the services that they need on the full spectrum of the healthcare industry. So that is kind of Molina's vision, our stance, and how we've supported our members through the pandemic, just to ensure, right, that they have the access that they need and the support that they need as they go through the system and try to navigate the complexity of our healthcare industry, which has been exacerbated by the pandemic, I would say. So along those lines, the panelists that we have here today are really in the front lines of providing that care and of strengthening our provider pipeline, because as you've heard, it has been a challenge, right? There's been a shortage. So the folks that you will hear from today are really our experts in that, and they've been working on increased access for education, training programs, and calling for diversity among the health force when, as I said, COVID has really exacerbated the challenge that we were already facing before the pandemic hit us, right? So today, we really, again, it's an important discussion, a focused discussion on what policymakers, advocates, and others in the healthcare industry are doing to address this, and how we can partner and strengthen those partnerships across the different sectors of the healthcare industry to support California's healthcare workforce.
Anita, that's a great way to begin. Thank you. And thank you for your incredible leadership. And thank you to Molina Healthcare, along with MolinaCares Accord, for bringing together today's expert panelists. Let me take the opportunity to introduce our panelists to you. Lisa Folberg is the Chief Executive Officer of the California Academy of Family Physicians, which represents more than 10,000 family physicians in California. Dr. Cozzette Lyons-Jones is the 31st President of the Association of Black Women Physicians. She is the Chief of Adult Medicine at Watts Healthcare Corporation in LA, joining the historic FQHC and practicing for 14 years as a primary care physician. And Andrea Schwab-Galindo is the CEO of the TVHC Health Center, an FQHC, and a board member of the Primary Care Association. Thank you all for joining us and for being here. Lisa, let me start with you, if I can. One issue that rises to the top when we talk about California's workforce is the provider pipeline, as well as training and residency programs. California lags other states in terms of the ratio of providers to people, and that physician shortages are more pronounced in rural and lower income communities. Can you start us off by framing where the provider pipeline is the weakest and where you see the greatest needs for expanding that physician workforce in particular.
Sure. And good morning, and thank you to Molina and to you, Jeffrey, and also to our webinar participants for taking the time to talk about the really essential and fundamental issue of healthcare workforce. I think there are at least three major problems. We don't have enough physicians, particularly primary care physicians. We have a skewed distribution and a lack of diversity. And this is a problem throughout California. There are 7 million Californians who currently live in health professional shortage areas, including some of the state's largest and fastest growing regions, including your new hometown, Jeffrey, in the Central Valley, Los Angeles, and the Inland Empire. These are also where we see a disproportionate number of communities of color, so they are disproportionately impacted by physician shortages, and particularly primary care physician shortages. Just to put it in some perspective, California is projected to have a shortage of over 4,000 primary care clinicians by 2030. We are ranked 37th in the nation at just 10 primary care physicians per 100,000 people. And by comparison, New York, which is first, has 33 primary care physicians per 100,000 people. So California is going to need to graduate hundreds more primary care residents per year in order to alleviate not only the current, but also the projected shortages. As far as pipeline, I think, the physician training pipeline is very long and unfortunately has holes all the way from sort of the lack of science programs in primary school, particularly in underserved areas, up to medical residence training. And I think more of a bottleneck than a hole in the provider pipeline is in residency programs and medical residency programs. Right now, California graduates more medical students than we have residency slots for. So they are forced to leave California when we really need to retain them, but they have to go elsewhere for their residency training. And studies show that where physicians do their residency, they tend to stay. So that is a huge problem. And I think the reason that I'm glad that you raised that in particular, I think while it is a huge problem, it's solvable. There are some programs that we're seeing that have been pretty successful in addressing that, particularly the Song Brown program. It's the only state program that funds graduate medical education exclusively for primary care residency programs. And it's the only program that takes into consideration recruiting minority physicians. There are other efforts in the state, including the CalMed Force program, but Song Brown is really the one that focuses on at least three of those major issues that I talked about: lack of primary care physicians, addressing diversity, and making sure that we have physicians in underserved areas in California. We have a long way to go, but I think there are some solutions out there. And as Senator Gonzalez had mentioned, there has been a lot of legislative interest in that. So it gives us some hope. So you don't think I'm all doom and gloom.
I don't think you're doom and gloom. I think you are the essence of reality. And I think, it's a great way to start off this conversation. Let me turn to Dr. Lyons-Jones. I'm hoping that you could give us some insight into the provider pipeline, particularly about what needs to be done to improve diversity and the importance of diversity to patient outcomes. I know the Association of Black Women Physicians leads a lot of work in this area, but what actions and investments need to take place to strengthen diversity and in our healthcare workforce today?
Thank you, Jeffrey, and I'm so glad to be here and be a part of this distinguished panel. As president of the Association of Black Women Physicians and as a primary care physician at a federally qualified health center, I look at the situation through multiple lenses. So I'm able to speak on both sides in terms of the diversity issue that we're facing within the workforce shortage that's exacerbating what's happening, that has been exacerbated by the pandemic. When you think about diversity is important to health outcomes. Research has supported and has shown out that when patients share racial identity with their physician, they have better outcomes. They tend to have better insight into their medical risk. They tend to have greater compliance over time or adherence to medical treatment plans over time and instructions given by their primary care physicians or doctors. And they also tend to be more accepting of preventive treatments. There's one study that demonstrated a reduction of about 15% in inpatient mortality when there was Black patients paired with Black physicians. There was another study that showed a 19%, I believe, reduction in the Black-white mortality gap for outpatient cardiovascular care, right, when there was concordance between race, between physician and patients. So we have the research to demonstrate the importance of diversity in terms of moving the needle and improving outcomes and eliminating health disparities. The elephant in the room is the fact that African Americans in particular represent 13% of the general population, and yet they only constitute about 4 to 5% of the physicians that are in the workforce nationwide, and that there has been a decline over the past 40 years in the number of Black men that have been accepted into medical school and actually successfully graduated. So these are areas of opportunity. When you're talking about the pipeline, we need funding throughout the pipeline. And I echo what Lisa has already stated up front. It starts back in grade K through 12, funding STEM programs and resourcing programs within communities of color is important at the K through 12 level. And then looking at areas of drop-off that are common within the pipeline. One area of drop-off would be the transitions from one school to the next. So when you're looking at students who are transitioning from high school to community colleges, and keep in mind that community colleges, that's where the majority of our workforce is being educated, if you think about it. So that's a huge area of opportunity where you have segregated at the bottom of the career ladder people of color, because of the fact that they're the disproportionate representation of direct care workers in these lower, paying professions. There's a necessity for having people at all areas of the pipeline, but we see a disproportionate representation of people of color at the bottom of the career ladder. So when we see the transitions from high school to community colleges to college to med school, these are all areas of opportunity in terms of being able to provide resources for building resilience in these students, providing financial incentives, support, so that they will be able to continue to be motivated to run the race to get to the MD. Another area of drop-off would be in standardized testing. We know for a fact that Black men who score low on the MCAT when they first take it tend to not retake it. Whereas Black women, they'll sit down and we'll take it again, over and over again. What is it that dissuades Black men from sitting again, from regrouping and having the information to be successful the second time around? We need to address that. So standardized testing and having a more holistic approach when we're reviewing applicants, when we're screening and selecting our applicants for medical school, can we have a more holistic approach and not just look at MCAT scores as the thing to filter out those people who we invite for interviews? When we have a holistic approach and look at the full breadth of what that candidate offers, then we're able to see that there's something there. There's something that we can support and foster and nurture to get that pipeline leakage stopped up at that level. So there's multiple areas of opportunity there in terms of the pipeline and improving diversity. And there is enough data to support our being intentional in putting our dollars and building contiguous pipelines starting at the K through 12 level all the way through so that we can do better with diversifying the workforce overall.
It's such a wonderful analysis of the situation, and it takes me back to, I grew up in Detroit, Michigan, and I lived that life. I'm the guy who took the SAT and gave up. But now, I'm terrible at standardized tests, and it wasn't, and so were half the guys I was in school with. But, I persevered, like you said, women do. I took the same thing and it wouldn't let anything stop me.
Yeah.
But I think about all the people who get stopped somewhere along the road, and those kinds of obstacles. And as we look at a public school system, because that's where many of the California residents are going, how do we combine, these issues in a public school system to give kids a hand up without getting them a hand out?
Right.
So it's enormous challenge. Let me turn to Andrea. You're and you're a CEO of an FQHC, and Dr. Cozzette Lyons is also affiliated with an FQHC. So let me stay at the beginning before anybody else does this. FQHCs are the lifeline for healthcare in California. What people don't understand is that that's where people go, because in rural areas where I live, in the California Central Valley, I got 4 or 5 different FQHCs and across 3 or 4 different counties. But for them, healthcare would be non-existent because you can't find doctors here. You can't find specialists. So thank you to you both for what you do with an FQHC. But Andrea, let me ask this question. In terms of meeting different kinds of patient needs and provider needs, what are the gaps that you're working with to strengthen the workforce to help maintain quality patient care?
Thank you, Jeffrey, and thank you, MolinaCares, and all for being here today. Workforce and leadership development is an issue that's close to my heart. And to your question, Jeffrey, we can definitely speak to that. For us, integrated care teams have been essential to responding to the pandemic and the worsening statewide shortages of healthcare workers. So contributions from every care team member, from our call center to our medical assistant, to our HR staff, have allowed us to quickly adapt amidst the uncertainty and the rapid change that the pandemic has brought on. And we all know that these issues were only worsened by the pandemic, but they've been there for a very, very long time. So for example, medical assistants and our community partners were critical in the administration of COVID-19 vaccines, working with providers to coordinate everything from that vaccine hesitancy to telehealth visits with our patients, how to get a hold of their providers. And our promotoras and community health workers work alongside them to address vaccine misconception. They were instrumental in really being able for us to have the reach that we did this past couple of years. And again, from everything from providing education to the use of technology for virtual visits. These professions and others have played a critical role to meet patient needs, yet many healthcare organizations across us and across the state and the nation are struggling to retain them. It's for this reason that we need to invest more in training and in leadership development. I'm extremely pleased that the state and the federal government and leadership recognize the value of community health workers and have expressed an interest in commitments to fund their training and growth. It's been our experience at TVHC, we've had promotoras and community health workers for close to 30 years. So we were one of the first in our area to know the importance that they play in our community, and what a key team member they are. And they're finally getting the attention that they deserve. In a similar fashion, I think it's important to stress and to talk about opportunities for emerging leaders. Participating in professional development has been critical in my personal role to the CEO. I've been in this role for a couple of years, and I've been really blessed to have mentors that have invested in me and have been intentional about pursuing those opportunities. But also these programs that I've participated in, like the Clinic Leadership Institute, the UCLA Executive Program for Community Health Center Leaders, both of which focus on the community, particularly in the community health center workforce. So we need more investments in those type of programs that support emerging leaders to be change agents who can undo the racial health disparities in our communities, for them to manage change, for them to develop place-based solutions and address the racial and health disparities that we have in our communities. When we have patients come through our doors, I want them to see in our staff, a reflection of who they are, and we have that, but we need to continue to develop that. For example, CPCA developed a leadership equity program in which I was part of the advisory committee in response to the need for greater alignment between communities accessing care provided by community health centers, FQHCs, and the diversity of future C-suite leaders. So I want to take this opportunity to urge our partners to also look for ways that they can support the training of healthcare workers and emerging leaders, CHWs, and to partner with community health centers. So thank you for those words earlier, Jeffrey. I do feel strongly that federally qualified health centers, community health centers have been pioneers of a lot of the workforce programs and have played an instrumental role in responding to the COVID crisis.
You know, I have followed your career on paper, and I am lucky, and where we are in the Central Valley, a colleague of yours, Leslie Abastis Cummings, is also one of my healthcare heroes because of what she's accomplished in Livingston Community Health. And but for leaders like the two of you and everybody on this call, we would be 10 steps backwards. We have 10 steps forward to go to. We have a long way to go. But the work that you and your colleagues have done has been phenomenal. And you can't be thanked enough, but you need to be thanked every day.
Thank you.
Let me turn back to Dr. Lyons-Jones for a moment. Andrea spoke of her experience at her FQHC. Your practice is at an FQHC. I'd love to hear how these issues are showing up in the FQHC space in Watts and what you're hearing from your colleagues around the state.
Right. So with the pandemic, we saw an exacerbation of what was already there in terms of being able to provide the talent that we need in terms of workforce to provide the care that we want for our patients. When the pandemic hit, I had to hold the hands of some of my coworkers as we let them go, as workers were furloughed. That was tough, especially if you were aware of some of the financial situations of these individuals. It made it even more difficult and challenging. We are in a space in which we are not reimbursed as robustly as we need to be in terms of Medi-Cal, right? And as a result, we're not able to compete in terms of the marketplace with larger health systems that are able to provide the salaries that attract the talent. And so oftentimes we lose workforce, we lose our employees to these other institutions because they have the means to be able to pay them the salaries that we cannot. And that is taxing. So during this pandemic, some of the ways that Watts has been able to approach or deal with these issues is, for one, we were able to give bonuses and compensation increases as a result of the American Rescue Family Act, Funding Act. And that was huge. That was important for us, and it allowed us to be able to make those moves to reward those people who were loyal to the organization, who had longevity, who were still there, and who deserved to have that increase in their salaries. We were able and have been able to successfully work with our local SEIU to be able to create tiers for our support staff functions. And so we can create MA1, MA2, spots, for example, so that it would encourage our medical assistants to stay and not to be attracted to these other institutions. So these are some of the ways that we were able to help to improve our workforce shortage issue, but we still have a long ways to go. And it's not just Watts, it's across all community health centers that are struggling in this area, unfortunately. Watts has historically been a nice pipeline for community programs to be able to partner and to bring people through to do preceptorships, internships, to have high schoolers come through and to be mentored so that they can be exposed to the healthcare system and to see what's possible for their futures, and to even form a connection to our community and want to come back and contribute after training as teammates. So we have the National Medical Fellowship that we have participated in for the past decade plus, and that allows scholars to come and do clinical rotations during the summer months at our institution. We go into career health fairs, like say for physician assistant programs, they, have career health fairs where we can hire on the spot, right there at the fairs. So there's different connections. Our relationship with Charles Drew University School of Medicine and Science is huge as far as maintaining that pipeline and that connection to hopefully motivate people from our communities, especially, and people who attend these institutions, to come back and to provide care and to support the communities that we serve. So I echo what Andrea presented as far as the landscape of FQHCs, but I'm hopeful for our future that we are prioritizing this in the face of this workforce shortage conversation that we're having and that we're facing nationwide.
One of the challenges in California that you face as an FQHC, and then Andrea faces as well, is the change in the 340B funding.
Yeah.
And how the governor has taken all that revenue away from FQHCs. And that's not revenue you're going to be able to make up. That's
Right.
revenue you use directly for patient care, for making sure you've got enough providers, et cetera. But I throw it out there, we can revisit that issue. It's, but it ultimately impacts the healthcare workforce because it limits your ability in terms of revenue opportunities to use those dollars for patient care. But if you don't have providers, you can't take care, it's a whole nother challenge. And somehow that logic, my words, has escaped those at the governor's office who think that what they've done with Medi-Cal managed care is the right approach, but I digress. Lisa, let me come back to you. Two areas of focus of the California Academy of Family Physicians are practice transformation and the need to invest more in primary care. Can you walk us through the coordination and delivery model of care and how it could be better structured, as well as the role that both play in addressing physician shortage?
Yes, and those two issues, they may seem like different issues, but as broken as our healthcare system is, it's still a system. And when you touch one part, it affects another part. And if you don't touch one part, you're not going to be able to make the system changes that you want to see. As we all know, our healthcare system is complex, and we could talk about this for the next hour or two. But I think the solution is also simple, as Dr. Lyons-Jones highlighted in talking about the challenges of workforce at FQHCs. We need to pay for and set up structures that support the things we want more of. So if we pay for more of those things, we will get more of that. Research supports that a key path to a more efficient healthcare system with better outcomes is more primary and preventative care. Don't get me wrong, we absolutely need specialists. We just need a balance. And I sometimes think of the healthcare system as the food pyramid, with primary and preventative care being the fruits and veggies at the bottom of the pyramid.
Right.
It should be the thing we consume the most of to keep our system healthy. Instead, we spend less than 10% of California's healthcare dollars on primary care. So we really need to change the incentives that are really perpetuating that, starting with creating incentives for our medical students to choose primary care. Physicians have on average $300,000 in student loans, which, just at the outset creates an incentive for them to enter higher paying specialties. There are some effective programs like the Steve Thompson Loan Repayment Program in Cal HealthCares that provides some loan repayment for physicians who choose to serve in underserved areas. But these really are Band-Aids. We need to change the culture and payment systems that are really valuing specialization over primary care. So I think that's one big piece of it is going back to that workforce piece. Another huge piece is that our current payment scheme of fee-for-service payments just isn't structured to support and sustain a comprehensive primary care system. So there really needs to be a shift away from that fee-for-service payment model, which promotes volume over value, do alternative payment models that promote population health management, care coordination, and integrating behavioral health. Again, some of the things that Dr. Lyons-Jones and Andrea talked about that are happening at the FQHCs. You know, one of the things that I think is really important to think about is we've seen some efforts at system change, including from the health plans, but those are really piecemeal. And if we want system change, we need to make whole system changes. So for physicians, for one payer to change the way that they pay, it often requires a physician practice or an FQHC to make some major changes in the way that they do their work. And it's often expensive and takes a lot of staff training. So we really need not just one sort of program to change, we need a whole system to change. We were involved in a pilot program in Fresno where we did just that. It was a pilot program working with the school district, and in less than 2 years, they were able to save over $1 million in moving away from a fee-for-service model that incented this volume-based payment to a model that created incentives for value-based payment. So, you know, we need all of these changes to kind of happen simultaneously, because we really do need system change, not just that piecemeal change. And as I said, we absolutely need our specialists, but I don't think we're utilizing them well when we're utilizing them as the patient's entry point into the healthcare system. I know family medicine better than the other specialties, and a family physician is a comprehensivist. They receive 200 plus hours of training in behavioral health, hundreds of hours of training in pediatrics and women's health, adolescent care, and of course, general adult medicine. And they're very well equipped to handle the myriad issues that a patient would bring and help that patient navigate through the healthcare system. So I hope I've answered the question. I think I need to stop there or keep going for the next 30 minutes.
You know, I could listen to you talk for the next 30 hours because the kinds of issues that we're covering are just so important to the task at hand. And as I like to say, I live in the Central Valley and we're a healthcare foundation. What we've done, we have 5 students in med school, and we're picking up 100% of the cost. In exchange for those, and at least 2 of them are in the UCSF Prime program. But we've got the students, we pick up 100% of the cost. They give us back anywhere from 3 to 5 years within our footprint of this Pike County area to come back. And we're focused on local kids to try to make sure that they're doing, and we're doing the same thing in other areas, but where foundation dollars can be used to help those students go to med school and, you know, don't have fear of debt and can say to the family, your child can go, we can afford to put him here or her, and we're going to pay for it. And we want them to stay in this community. So it's, you know, it's the luxury of having charitable dollars to be able to do that and to be, you know, collaborative with some of the institutions. But plus we have UC Merced and UCSF starting a new BA MD program next year, which is extraordinarily exciting. And we can't wait to see, you know, what that brings. Andrea, let me turn back to you as a board member of the Primary Care Association, who has advocated for funding in this year's budget to support California's 1,300 community health centers. Can you spend a little time talking about what increased state funding for community health centers would do to increase access to an underserved community and the role of California's community health centers play in meeting the medical needs in all of these communities?
Yes, thank you, Jeffrey. So community clinics have played and continue to play a critical role in meeting the needs of our community. So, you know, we've said it before, we've been at the forefront of the pandemic and have been leading whole person care within communities of colors for decades. I We believe that greater diversity and cultural humility are key to rebuilding the healthcare workforce and ensuring access to all California. I agree with Lisa that we need to move beyond the piecemeal change, and with Dr. Lyons-Jones in that cultivating healthcare professions pipeline that more closely reflects California's diverse population are needed. I think this starts with recognizing the systemic barriers that inhibit some of the individuals who train and work as healthcare providers. As you mentioned, we need community partners. We need foundations that will invest in our communities, that will invest in our people. And in terms of the state, the governor has made some significant health workforce investments in his proposal budget this year. But I think that more could be done to fill the large workforce gaps that persist across the state. So what California Health Plans advocates and CPCA have done is that they have spent the last several months working with community health centers. I'm the legislative chair for CPCA, and we really have tried to partner with all of our leaders to create a workforce budget that consists of new state investments. So our goal is to incentivize primary care, allied health, behavioral health students and professionals from our local communities where we are to enter, train, and practice within our medically underserved populations, particularly those served by community health centers. So our workforce budget ask is divided into three areas. Let me make sure I get these numbers right. We have $29.3 million for scholarship and loan repayment programs, $16 million for advanced practice clinicians trainings program, and $5.7 million for graduate medical education. These investments are critical given the COVID-19 detrimental impact on our healthcare providers, which really has, and this is something that we've talked about it, but I think we need to continue to talk about it. It's the increased rates of burnout that our professionals, that our communities are facing. Early retirement. I've known a couple of our nurses that have retired. They were planning on working for another 5 years. The past 2 years have been too much. Labor market competition amongst health employers. We can't compete as a nonprofit, as community health centers, with some of our other healthcare providers, and the rising cost of healthcare. And this type of investments can really increase the number of primary care, behavioral health, and allied healthcare professionals that are working in our community. Not only that, but the recruitment, the retention piece, I think is critical as well, and will also help with inclusivity within the health workforce. And for us, something that I think we do really well is that it gives us the opportunity to grow our own workforce by training and hiring from the communities that we serve. If we, I like to say at TVC that we hire from our community to serve our community. And really, many of our staff live within the cities that we work. I believe last time I checked, there was something over 70% of our staff worked or lived in the areas that we serve. So we really want to create a strong culture, a really great working environment to continue the health center movement. This is something that I'm extremely passionate about, and serve Californians who otherwise wouldn't have access to healthcare. They wouldn't know where to go.
I love the line, hire from our community to serve our community. Mm-hmm. As I think about what Lisa said and Dr. Cozzette Lyons has said, it would be great to say, educate from our community to live and serve our community.
Would love that, yeah.
Wouldn't that be great?
Yes.
And I can't thank you enough, because I know the kinds of things that you're doing, and I'd be remiss if I didn't constantly say thank you. Let me shift real quick back to Nita and bring her back into the conversation. There she is. The panelists have discussed actions that are being taken at a systems level and a policy level to address gaps and expand capacity in healthcare. What are the ways that health plans, and just speak purely from Molina's perspective, because you can, to address these kinds of issues?
Sure, Jeffrey, thank you for that question. So we saw, and I had the opportunity to kind of talk generally too with our leadership about this, is because this is an evolving conversation, right, that we constantly have. But for health plans, it's really kind of two-pronged that we need to think about it. It's our own staff and retention, right? What can we do for our employees who are experiencing some of this burnout, or folks that were, previously face-to-face or on site with our providers or hospitals, and, how we can encourage them and keep that going where so many of our competitors or different organizations are offering that, work from home kind of solution and things like that. So it's evolving, I believe, to offer that flexibility to our staff to provide those modern solutions to meet our employees where they are at, especially given the pandemic, right? And the changes that have come from that with children, childcare, school at home kind of situation, how we can meet our folks to provide solutions like alternate work schedules. Are there opportunities, for example, certain teams, given their functions and things like that, how can we expand their capabilities and support a more work from home environment for our folks that are face to face or need to have that face to face interaction? How do we ensure their safety as they go out, right? In some of our most vulnerable communities to meet our members. How do we solution for that and give them the support that we need, or offer, additional kind of perks or benefits, incentives, right, with a different work schedule and alternate work schedule that really takes into account their circumstance while managing, right, our goals and the health plan workload and things like that. And that's kind of what we've done, and looked at folks sometimes on an individual basis, right, to really work with our staff and our employees and address that human element, because it's not just about numbers and productivity. It's about, quality care from employees that are motivated and that are encouraged, right, to continue doing what they do best and caring for our most vulnerable members with the support from us as leadership, right, to carry that out. So that's kind of addressing the health plan staff. But in terms of the community and supporting our providers, we at Molina of California, we're really looking at the communities that we service and how do we work with our partners, our community-based organizations, our social support organizations, to understand what their capacity is and where we can lend support, whether that's financially or through another resource, like a staffing resource. For example, we have listened and understood our hospitals and the challenges that they have, especially during the pandemic and all this time. So we looked at and actually working to embed some of our health plan staff at the hospital. So we have that direct resource and connection to us, and we facilitate that discharge planning. We've staffed up some of our teams that are 24/7 to provide ongoing support to our hospitals, and just really, understanding kind of where their gaps are at, where we can fill that with our resource. And financially speaking, I'm sure most folks have heard of the governor's initiative of CalAIM, the California Advancing and Innovating Medi-Cal Initiative. And there's so many different facets of that. But one of the things that we at Molina of California, we're happily participating in and really taking a deep dive into is the incentive payment program that we're participating in, where we're really partnering and identifying needs in the communities and what our providers may need to build their capacity or strengthen their workforce, and how we can financially support those needs to stand up. Things that are identified, like whether that's a sobering center in the community and helping support the staffing related to that, or certain programs that they have. How do we, financially support the FTEs that they need, or the care managers, the RNs that are needed to deliver those cares. So we're actually pretty excited. There's a lot of financial analysis and work that goes into that, but we're really excited to see how we can kind of pool resources and partner not just with, other health plans, but really the community as a whole to lend that kind of support for everyone. So that's just a few things that we're thinking of at the California Health Plan, and that we're acting on just to offer that support and fill the gaps where we see them. Oh, Jeffrey, you're on mute. Sorry.
I muted myself. And those are significant, and the challenges that CalAIM presents are not small. They are wonderful conceptually, and but concept and reality are two different things. And how you and your colleagues and other providers across the state are able to bring all that together in a cost-effective manner and still make money, because at the end of the day, you still have to drive revenue that's going to be able to support what you're doing, is a significant challenge that I'm still looking forward to having that conversation at some point. But let me throw to everybody, and thank you for all joining us today. Let me throw one last question out for everyone to participate in. The pandemic has been a disruptive and uncertain time. Over the past 2 years, we've seen existing challenges deepen, particularly in the most underserved communities, at the same time as we've seen progress in terms of new investments and supports at both the state and federal level. What do you think is the most important thing the state could be doing to strengthen healthcare, particularly a healthcare workforce, to improve health outcomes and ensure access to quality care? Lisa, let me start with you.
Sure. Well, I'll just say, COVID-19 probably didn't create new problems, but highlighted and exacerbated healthcare system weaknesses. Andrea, Dr. Lyons-Jones, they can tell you that disparities, healthcare disparities and primary care practice financial insecurities, limited access to care, provider burnout, these existed long before the pandemic, but of course were made worse by the pandemic. And so I think a huge part of that is certainly system reform. But in order to build the house of system reform, we really need to have a strong primary care workforce foundation. And I think there are things that we can do now per your question, Jeffrey, including funding the Song Brown program. It's been an essential program for providing funding for graduate medical education programs that focus on diversity, that focus on primary care. So that's something that we can do with legislative help this legislative session.
Okay, Dr. Cozzette Lyons-Jones.
Totally agree with Lisa. I feel like I need to connect with you after this. You echo so much that's in my heart. Improving practice viability in underserved areas is important. And that can be achieved through increasing the Medi-Cal rates. That would allow community health centers to be able to compete in the marketplace and to attract and retain talent. It's not likely to happen, sad to say, in my opinion, but we have to take into account that we are a high cost of living state, and that we underpay for the services that are provided to a third of the insured, and we have to do better. So that's an area of opportunity. I am proud to say that I am a recipient of the National Health Service Corps loan repayment benefit. And so for me, being able to continue to support that, to channel monies there, to continue to channel monies into Title VIII, Title VII. It's about money at the end of the day, in my opinion, because money is what allows you to be able to expand, capacity, allows you to be able to go in and correct areas of opportunity, allows you to be able to do more and to attract more people. So it's money, 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 in my opinion, is the short answer.
Andrea.
Great. I agree with that, Dr. Lyons-Jones. Money, money, money. But I'll focus a little bit on this, on behavioral health care. We in community health centers, we believe that it should not be separate from the rest of the body. And we are really something that we're great at, right? Integrated care. And we know that fragmented care contributes to poor outcomes with people, particularly in communities of color. So the ability to coordinate care under one roof helps to alleviate some of the dual diagnosis and achieve well-being. For us, the ability to utilize associates has alleviated some of these challenges. So in May of 2020, DHCS, temporarily allowed for for ASWs and AMFTs as billable providers for FQHCs, contingent at the public health emergency. This flexibility has greatly increased access to behavioral health care in our communities. In fact, we've had one position that's been open for a licensed behavioral health professional for over 10 months, and we have not been able to, we're not even asking for that person to be bilingual. So if this allowance isn't extended beyond the public health emergency, access is going to decrease, and the demand for services is higher than ever. So again, the looming healthcare concern for community health centers is that lack of funding, workforce, really being able to implement integrated healthcare. And Senate Bill 966 would extend these flexibilities past the public health emergency. So this is something that we're advocating for.
I can't thank you all enough. This has been inspiring, because when my heart sings, my day gets better. So thank you. When we talk about the gaps in the workforce, we have to also talk about the need for physician assistants, the need for nurse practitioners. I'm proud to say that our foundation created a nurse practitioner program at Cal State Stanislaus. We've graduated 45 so far, half of whom have been on scholarship and stay in the community to work. And hopefully with corporations like Molina Healthcare, we will get better faster as opposed to not. But we'll really get better because of the leadership of all of you. And thank you for making my heart sing today. I can't thank you enough.
Thank you.
Thank you.
Thank you.
Anita, great job. Thank you for helping make this a reality.
Yeah, thank you so much for having me.
All right. And with that, we will stop, and I'll bid everyone adieu.